All right, so let's continue on part two with chronic kidney disease. So, when we talk about chronic kidney disease, we see that 1 in 7 Americans have this, which estimates to about 37 million people. So, when we talk about chronic kidney disease, it is a progressive, irreversible loss of kidney function. This can happen over months or even years, but we see a slow increase of your BUN and creatinine and a decrease of your GFR. It is usually a longer onset and is usually caused by long term chronic conditions. Again, it is irreversible and it is often asymptomatic in the early years. So, unfortunately, usually by the time it is recognized and noticed by the patient, they are in that later stages. We have many complications such as cardiovascular disease, anemia, hyperkalemia, acidosis, bone disease, and fluid overload that we see with those later stages. Remember when we just talked about in acute kidney injury, all the things that the kidneys do to help maintain that body's homeostasis. So when we have that chronic disease, we really develop a lot of complications. We do see a higher incidences in this with people that are over 60 years of age. And just that we notice it is higher in African Americans and Native Americans and higher in men versus women. So, some of our risk factors that we see is diabetes, which is one of the leading causes due to that damage from the high blood sugar levels that affect that glomerular filtration in the kidneys. Hypertension, again, that causes damage to the blood vessels in the kidneys and restricts the blood flow. Hyperlipidemia, which gives kind of a clogging to those vessels and decreases that blood flow. Smoking can cause vascular constriction. Use of recreational drugs provides toxins to those kidneys and decreases that flow. Again, same thing, nephrotoxic drugs such as NSAIDs, obesity, and then things such as glomerulonephritis or polycystic kidney disease will reduce that blood flow to the kidneys as well. Some of the clinical manifestations that we see, again, we talked a little bit about that with acute kidney injury, but remember, it can affect the whole body systems. So we see alterations in sodium and fluid balances that can result in hypertension, heart failure, pulmonary edema. Your altered potassium excretion can result in lethal arrhythmias, impaired metabolic waste elimination that can result in uremia, many GI symptoms such as nausea, vomiting, anorexia, and even neurological symptoms such as headache, lethargy, fatigue, confusion. And ultimately, without treatment, those toxins can build up and you can have seizures and possibly coma. Altered calcium and phosphorus levels can result in brittle bones and breakdown of the bones and have defective development. You can have decreased acid clearance from the bicarbonate production, which that will result in higher incidence of metabolic acidosis. It can affect your endocrine and reproductive functions. So you will see infertility, amenorrhea, possibly hyperparathyroidism and thyroid abnormalities. And again, if our kidneys aren't working, we have a decreased production of that erythropoietin, which can cause chronic anemia. So we see that it affects all areas of the body. This is just a little chart that came from your book, which kind of shows that what each area that the kidneys do and how it can affect us with our body systems. So, looking at kidney failure, we can put this into stages. And the stages are typically based on your GFR, which is your glomerular filtration rate, goes from stage 1 to stage 5. And this is what's going to give us a clear functioning of how well the kidneys are working and what stage of kidney disease they're in. So, stages 1 through 3 is typically classified as an early chronic kidney failure. Stage 1, you have a GFR greater than 90. Most of the time, patients are going to have normal renal function, and they're often asymptomatic at this point. Stage 2 is where we have a GFR of 60 to 89. This is where we're going to see some instances of possibly hypertension, increased BUN and creatinine, possibly seeing blood or protein in the urine. Stage 3, we have a GFR of 30 to 59, and patients may start experiencing more symptoms with this. So, fatigue, maybe hypertension, maybe more edema, peripheral edema, fluid overload. And usually at this point, when they start having these type of symptoms is when they're going to the doctor, having lab work done, and we notice those lab alterations and start looking into this. Stage 4 or 5, this is we consider more advanced end stage renal disease. Stage 4, we have a GFR of 15 to 29. And at this point, your patient's going to have severe fatigue. You're going to notice that fluid overload, electrolyte imbalances, so you're monitoring for that hyperkalemia. They possibly will have that uremia symptoms with nausea and vomiting. You notice more anemia due to the decreased erythropoietin, and hypertension usually follows. Stage 5, you have a GFR of less than 15. So this is considered complete kidney failure. You have all the above symptoms, plus generally if it's not being treated, you're going to have cognitive changes, see the patient with metabolic acidosis, and you're definitely considered end-stage renal disease, possibly not making any type of urine at this point. So we always want to make sure that we are encouraging our patients to notice these subtle changes with their bodies and advocate to have them checked out, right? To have your patients have regular screenings. When we look at chronic disease, chronic kidney disease, and medical management, we see how are we diagnosing these patients. Again, when they start having some notable symptoms, we're going to do blood work. We're going to see elevations with the serum creatinine and BUN. Remember when we talked in acute kidney, that BUN is your blood urea nitrogen. That's what's building up from those toxins not being filtered. Your GFR is your glomerular filtration rate. And again, that's used to classify and determine your kidney stage. And that's usually the worse it is, the lower it gets. We're going to monitor those electrolytes. So we notice hyperkalemia, hypermagnesium, hypocalcemia, hyperphosphatemia, and these will develop more in those advanced stages. We're going to look at the protein and albumin in the urine. Generally, when your kidneys aren't filtering, you're going to see higher levels of those. The uremia is present, again, due to not being able to filter out those toxins and waste products. We're going to look at possibly urine tests, check the albumin to creatinine ratio, which is what's going to help detect the protein in the urine. That is an early indicator of kidney damage. And looking at the urinalysis itself, we're going to look at blood, protein, and any abnormal cells that could be causing the damage. We do imaging such as an ultrasound or CAT scans to evaluate the structure and size, and possibly even a renal biopsy, which will help provide additional information on the status of the kidney and how exactly it's functioning. Looking at medical management of kidney disease, remember it is something that is progressive and it is irreversible. So we definitely want to look at what we can do to maintain their kidney function and help keep them feeling better. So we look at lifestyle modifications. We're going to have dietary restrictions, low sodium, low protein, low potassium, and low phosphorus diets. It's okay to have those lean proteins and carbs, but we don't want to have excess proteins because they're not able to filter those out with those toxins. So think about the foods that we would have to omit. We want to do fluid management. Often these patients have an excess of fluids and have fluid overload. So we might need to limit in those later stages to avoid this. So we want to limit their fluid intake and limit that sodium intake to help keep that down. We always want to make sure our patients know that they should not gain more than 5 pounds every 2 days. or over 2 days. We want to help control those electrolyte imbalances. So we're monitoring for sodium and potassium, magnesium. We want to help them to make sure they're controlling their hypertension, looking at anemia because of that decreased erythropoietin. They can have dyslipidemia, renal ododystrophy, which causes that brittle bone. So those are treating those clinical manifestations that can occur from just kidneys not working properly. We're going to look at their medication management. We want to make sure that they're taking antihypertensives because most people with chronic kidney disease develop hypertension. Often you see them being given ACE inhibitors or angiotensin blockers, which will help also slow that progression of the kidney damage. Patients are usually given diuretics to help manage that fluid retention, and it'll also help with hypertension. So again, our patients should be monitoring daily weights, making sure they don't gain over 5 pounds in 2 days. We want to monitor those potassiums, especially taking diuretics, dependent on if they're a loop diuretic, which is a potassium wasting, or a other type of diuretics like a spironolactone, which is a potassium sparing. We want to make sure they're monitoring, is it too high or too low? Also, taking diuretics, we want to make sure we're teaching our patients to avoid getting up too fast, avoid that orthostatic hypotension, and to make sure they're taking them first thing in the morning. We don't want our little peoples getting up in the middle of the night multiple times because that can increase their risk for falls. They might be taking phosphate binders to help control those high phosphate levels. And they might need to take calcium and vitamin D supplements to help maintain and prevent an increase of bone disease. And ultimately, if medical management isn't working and we continue to see a decline of their kidney functions, we might need to consider renal replacement therapies, which is a type of dialysis that we'll do to help remove those toxins and waste buildup that the kidneys aren't able to keep up with. And we'll talk a little bit more about those in just a little bit. So one of our other treatments that we might consider is surgical management. So with end-stage renal disease, our patients might be placed on a transplant list. And so this is where we would look at that. So patients do need to remain compliant for a lifelong treatment plan if they have renal transplant. So any comorbidities such as hypertension, diabetes, heart disease, they need to maintain that because they could regress and have a renal failure with the new kidneys. And also to remember they're going to be on lifelong immunosuppressive therapy, which can, they have to be real cautious with that. So typically transplantation is done with kidney stage 5 disease, when the kidneys are no longer able to filter any type of waste products, you are no longer making urine, and you're having to maintain that balance on dialysis. We use either living or cadaver donors. Typically, the old kidneys are left in place and a new kidney is transplanted in, which you see on this picture. The only time that we would remove the kidneys is if we see a hyperacute rejection, which we will talk about. But as you see through this picture where the new donor kidney is implanted and grafted to your arteries and veins in the bladder. So some of the complications with rejection after renal transplant is you can have a hyperacute rejection. This can happen minutes to hours after the grafting takes place. With this, your body is acutely rejecting this kidney. This is something that would need to be removed. So you can't keep the kidney in there if the body is continually trying to reject it. And like I said, we know that within minutes to hours. You can have an acute rejection, which happens typically within 3 months. This is where you're going to notice fever, swelling, tenderness over that graft site, a possible start of oliguria or decreased urine output, and a rise in those BUN and creatinines. For this one, they might consider increasing your dose of immunosuppressants to try to help the body accept that kidney. And then you might have a chronic rejection, which is primarily the cause of a graft loss. Again, these are patients that have all those comorbidities that just because of that, the kidneys can't keep up. So you'll notice the azotemia that we talked about, protein in the urine, increase of hypertension, the oliguria, and management that they had before with their chronic kidney disease. Some of the other complications we might see is hypertension, renal artery stenosis, renal vasoconstriction, and glomerular lesions within the kidney. And again, we need to make sure these patients realize they are going to be on lifelong immunosuppressive therapy. So they have to be really careful about being exposed to infections. It can cause, or being around if you develop any type of cancer or tumors or any congenital abnormalities, that can cause further complications. Again, the clinical manifestations that include the all body systems. We kind of already talked about that, but just remember that the kidneys, are more than just your urine output. They really include your cardiovascular disease, your lungs. It can be cause pulmonary edema, alterations in your body balance of fluids. It can cause GI symptoms, bone breakdown, reproductive issues, thyroid abnormalities, anemia, all those things that we talked about. Just remember the kidneys control so much of what the body is happening. All right, looking at some of the nursing diagnoses we would use for chronic kidney disease. So excess fluid volume, that's related to the renal failure and that renal fluid retention. Disturbed thought process. Remember, if we're building up those uremic toxins in the body, that's going to be really hard on your central nervous system and cause that confusion. We can have fatigue related to that anemia, that decreased blood production. It can be related to metabolic acidosis or even that toxin buildup. We can have complications such as dysrhythmia. Remember, we have those electrolyte imbalances that could be causing this. And along with that higher toxin buildup, we have anorexia, we have nausea and vomiting, and then the bone demineralization due to that decreased production of the erythropoietin. So we're going to look at our assessments. So when we have just a recap, or let's just recap on some of our information. So we want to monitor those vital signs, those oxygen levels. We want to make sure that their hypertension is being controlled and that oxygen saturation is adequate because we're watching for that presence of fluid overload, pulmonary edema. We want to monitor their cardiac and peripheral vascular system. So listen for that fluid overload. Check your breath sounds, make sure there's no rales. Peripheral edema, you're looking at that excess peripheral fluid buildup, looking for neck vein distension from that. You're monitoring your laboratory data, looking at that potassium, because again, hyperkalemia can cause severe cardiac dysrhythmias. Monitor your sodium. That can also help determine your volume status. Your serum calcium and serum phosphate. Again, that's going to cause so many bone issues. So we want to make sure that we're giving phosphate binders to help pull that phosphate down and giving replacement of the calcium and vitamin D to help with bone health. Your hemoglobin and hematocrit can be decreased due to that decreased production of erythropoietin. We're monitoring our ABGs. Why? Because again, the kidneys help monitor that fluid-base, acid-base balance. So typically we're going to see these patients in a metabolic acidosis due to decreased hydrogen ions and decreased bicarbonate production. If our patient has had a transplant, we definitely want to make sure we're monitoring vital signs, oxygen, temperature, pain. We want to look for any type of rejection. Um, Again, with transplant, these patients may not be as mobile, so we want to make sure that they are moving as tolerated to help from developing atelectasis or pneumonia. Any increase in temperature could signal an infection, and we just want to make sure that they're moving again, keeping healthy. We're going to look at those incision sites for redness, warmth, drainage, look for any acute rejection signs, monitor those renal function tests. An increase of urine and creatinine or a decrease in the GFR may indicate a rejection. Monitor your intake and output. Again, urine output can be increased due to the improved clearance of the BUN. That kind of, when it first goes back to normal, it acts as that osmotic diuretic, like we talked about in the acute kidney injury. It just, you might have a massive overflow of urination. So you want to make sure you're monitoring those electrolytes again and making sure that our patient is staying equally balanced with all their electrolytes. A little more recap. Again, cardiac monitor. We're looking for that hyperkalemia, making sure that the patient's not having any problems. We're maintaining their weight. We want to make sure they are weighing at the same time each day, usually typically done before dialysis. Use the same type of scale and record and maintain these weights. Accurate information helps us know their fluid status and helps us kind of go with their dialysis plan of how much fluid needs to be removed. We want to possibly restrict fluids and sodium. Um, the kidney's inability to remove this excess fluid, so this is going to help keep the patient from developing fluid overload. We want to make sure that they are taking the prescribed medications, whether it's to treat hyperkalemia, treat their blood pressure, treat high phosphates, or calcium supplementation. We want to make sure they understand all the things that need to happen to help keep their system healthy. Patients can possibly have synthetic erythropoietin given to them to help maintain that adequate hemoglobin and hematocrit levels and keep them from being so anemic. Another thing that might help keep with development of anemia is giving a supplement of folic acid or ferrous sulfate. And unfortunately, a lot of times with this, patients are going to get constipated, so you might see chronic kidney disease patients with stool softeners. We want to look at their skin care. These patients can be on a fluid overload, so they may have edema, peripheral edema, which is going to decrease their tissue perfusion and they're at risk for skin breakdown. Make sure that they have proper positioning, not only for skin breakdown, but make sure they're sitting up and they're able to breathe and facilitate those good inspirations and keep from getting pneumonia or atelectasis. We want to monitor their diet, make sure they have adequate protein levels, but avoid a high level of protein because that's going to be harder for them to break down. And then if they're post-transplant, they know they have to maintain their immunosuppressive medications and monitor for any signs of rejection. And just a little more teaching here to talk about is make sure that they do not miss any dialysis appointments. They know their dietary restrictions. They understand the manifestations of chronic kidney disease and they're following up with their doctor. They're avoiding nephrotoxic substances such as NSAID, contrast media, certain antibiotics, and alcohol. They're doing their daily weights and again, monitoring those post-transplant reactions. The next little section here I just want to talk about is about dialysis. So, renal replacement therapy is just an artificial process for removing that waste and water from the body when the kidneys are no longer able to function adequately. The renal replacement therapies include hemodialysis, CRRT, which is continuous hemofiltration, continuous renal replacement therapy, and peritoneal dialysis. So what happens is solute and water movement across the semipermeable membrane, and it helps pull in those toxins and then excrete them. So dialysis is indicated for both acute kidney injury temporarily or end-stage renal disease. Um, Typically, it is acute kidney injury just to maintain while the kidneys are healing, and of course, an end-stage renal disease because the kidneys are no longer functioning anymore. We want to make sure we talk about the different types and who is the best candidate for each one. So when we look at hemodialysis, we have a couple different access. We have a fistula that could be surgically implanted into the patient's body. So we see an arteriovenous graft or arteriovenous fistula, and this is what you will see for long-term dialysis patients. This is where you see their fistula in their arm. You're going to palpate that and feel the thrill, or listen to it with your stethoscope and auscultate the bruit. Um, we want to make sure that we teach these patients that that arm or that extremity with the dialysis fistula should avoid any type of constriction. So any type of tight clothing, tourniquets, no lap draws, no blood pressures taking. Don't carry weights or bags on that arm. Don't sleep on that arm. We don't want to do anything that could crush or injure that dialysis graft. And then we have a temporary dialysis graft, which I believe you guys learned about in 200. It's like a double lumen implanted catheter that they use temporarily. This can be used in acute kidney injuries or through the end stage renal disease while the fistula is healing and being ready to use. So, the process of hemodialysis, again, the blood is removed from the body, pumped through the dialysis, and then remove the waste, and then it is returned to the body. So, hemodialysis is typically performed in outpatient centers, inpatient hospital settings, and sometimes can be done in home settings. Continuous renal replacement is the same type of filtration as hemodialysis. However, it is done at a much slower rate. It can take up to 12 hours for this to happen. It is required to be done in an ICU on a one-on-one care. If the patient does not have a fistula, they would have an arterial or venous line together to be able to do this. And then peritoneal dialysis is the process where the patients usually typically do this at home. It filters through that permeable, cannot talk today, semi-permeable membrane in the belly. So you would have the patient would have a fill of the dialysate, it would set, it would gather the waste products, and then you would empty it out. We'll talk more about the dialysis treatment like this in our lab station. But typically, this is done at home. It goes over several hours. Patients should be able to physically understand it and do it, as it is a high risk for infection. So we want to make sure that they understand that sterility process. We want to make sure they understand that that fluid accumulation in the abdomen can push up on their diaphragm and cause shortness of breath. It is not meant for a rapid treatment. It is a very slow process.